Please allow me to present our work on pigmented and non-pigmented actinic keratosis about dermoscopic clues and correlation with phototype. Actinic keratosis is a precancerous lesion induced by prolonged exposure to UV radiation with the risk of development into squamous cell carcinoma if untreated. Actinic keratosis are divided into two categories based on the presence or absence of clinical pigmentation. Clinical diagnosis can be quite challenging, especially on hypodermal skin, hence the importance of dermoscopy compared to the naked eye. The dermoscopic signs of actinic keratosis have already been reported in the literature. Our study aimed to go further and determine the sensitivity and specificity of these signs in distinguishing between pigmented and non-pigmented actinic keratosis, and in the second line, to search for significant association between the degree of pigmentation and phototype. To do so, we conducted a unicentric, prospective, descriptive, and analytical study. Both pigmented and non-pigmented actinic keratosis of the face and scalp were included. Dermoscopic images were obtained using polarized and non-polarized light contact dermoscopy coupled to a smartphone and interpreted by two experienced clinicians. Lesions were then classified into 5 categories according to the intensity of pigmentation. With no pigmentation, pigmentation less than 25%, between 25 and 50%, between 50 and 75%, and more than 75% of pigment. Statistical analysis was performed using JAMOVI. 2 types of analysis were performed, a descriptive analysis and analytical univariate and multivariate analysis. A total of 200 lesions of actinic keratosis in 91 patients were included in our study. 75% were pigmented and 25% were non-pigmented. Regarding the anatomical location, the cheek was the most site followed by the nose, forehead, ears, and scalp. According to the Fitzpatrick skin type classification, the majority of our patients were phototype 3, followed by phototype 4. Based on the results of dermoscopy in our study, 37% of actinic keratosis had more than 75% of pigment, 25% were non-pigmented, 15% had pigmentation between 50 and 75%, 14% had less than 25% of pigment, and 9% had pigmentation between 25 and 50%. Different dermoscopic features were observed in the lesion, especially white scales. They were observed in 75% of lesions. Pigmented scales were also observed in some lesions. Rosettes were seen in 73% of actinic keratosis. The pigmented pseudonetwork was observed in 58% of actinic keratosis, followed by the red pseudonetwork in 46% of cases, then jelly sign in 27% of actinic keratosis, rhomboidal pattern in 26% of lesions. As for white circles, they were noted in 20% of cases. When yellow follicles were observed in 18% of actinic keratosis, the granular annular pattern was detected in 17% of lesions. The gray halo in 15% and starburst pattern was detected in only 9% of cases. As for analytical results, the main statistically significant feature of non-pigmented actinic keratosis was red pseudonetwork. It had high sensitivity and moderate specificity. Concerning pigmented actinic keratosis, the significant dermoscopic signs were pigmented pseudonetwork, granular annular pattern, jelly sign, gray halo, and rhomboidal pattern. They were specific of pigmented actinic keratosis, while rosettes were more sensitive than specific. Finally, to investigate whether there is an association between the intensity of actinic keratosic pigmentation and phototype, logistic regression was used, and a significant relationship was found. This means that a patient with a darker phototype has 1.5 times higher risk of developing pigmented actinic keratosis, with a confidence interval between 1.22 and 1.86. In our context, pigmented actinic keratosis are more prevalent, making it imperative to explore specific and sensitive signs indicative of pigmented actinic keratosis. While many studies have investigated actinic keratosis in general, very few have specifically detailed the dermoscopic signs that predict pigmented actinic keratosis, making our study very pertinent. Our findings broadly align with studies conducted by Nascimento and Eke regarding the frequency of dermoscopic signs significantly found in pigmented actinic keratosis. Indeed, Pigmented pseudo-network, rhomboidal structures, undergranular pattern, and gray halo were the most frequently observed dermoscopic signs, as shown by our results and those of the mentioned studies. However, concerning the specificity and sensitivity of the dermoscopic signs, the gray halo was more specific to pigmented actinic keratosis with moderate sensitivity, as also reported by Ekai, whereas it was more sensitive and less specific according to Nascimento. Comparing our study to that of Sgurus, we found that pigmented actinic keratosis was more prevalent in our context, with the pigment intensity more than 50% being higher, whereas Sgurus reported the pigmentation more than 50% in only 7% of cases. Regarding non-pigmented actinic keratosis, we found that the red pseudo-network was more sensitive than specific, which aligns with Sgurus' study. For pigmented actinic keratosis, the brown pseudo-network was highly specific, contrasting with the literature. To the best of our knowledge, we were the first to establish a significant association between darker phototypes and pigmentation intensity in actinic keratosis, which signifies that in our population, we will find pigmented actinic keratosis as the phototype becomes darker. To conclude, a detailed dermoscopic analysis allowed us to highlight the most specific and sensitive signs for the diagnosis of both pigmented and non-pigmented actinic keratosis. In fact, pigmented pseudo-network, granular annular pattern, jelly sign, gray halo, rhomboidal pattern were specific to pigmented actinic keratosis. And finally, according to our results, we can expect to observe pigmented actinic keratosis in our patients. And finally, I want to thank all our professors and especially Professor Mernissi. Thank you for sharing your love and for your passion and expertise of dermoscopy with us.